The purpose of this video is to provide general information and education about the care of a critically ill child. It is in no way a substitute for the independent decision-making and judgment by a qualified healthcare professional. The information contained in this video should not be used to make a diagnosis or to overrule the advice of a qualified healthcare provider, nor should it be used to provide advice for emergency medical treatment. Non-invasive ventilation. Complications by Dr. R.Graham. Please note that in this video we will be following the guidelines used at Boston Children's Hospital. Some of this information may need to be modified based on the equipment, guidelines, and practices in place in your institution.
Hi, I'm Dr. Robert Graham. I'm an associate in the Division of Critical Care Medicine with the Department of Anesthesia at Children's Hospital Boston. Today, I'm going to talk to you about complications of non-invasive ventilator support. There are complications, as we've sort of talked about, when considering non-invasive ventilation. Skin integrity is definitely a concern. And there are a variety of types of interfaces, and I often would recommend that people consider alternating between interfaces. 12-hour periods alternating, every other day alternating. When you have something that's pressure on your face, either just a nasal mask, a full nasal mouth mask, or the full hockey mask, they're actually non-invasive ventilations that encompass the entire face, that the pressure points over the skin can cause skin breakdown, actually decubitus ulcers, if you will, that are a nice nidus for infection. This is definitely a concern, especially for our immunocompromised patients, and something that we watch for very closely. You can sometimes circumvent these by placing different types of barriers and different types of skin care underneath, or simply, as I said, alternating the mask and loosening or tightening appropriately. Gastric distension is definitely a concern. Almost anyone who's on non-invasive ventilation will have a degree of aerophagia, where they are swallowing air in addition to inflating their lungs. This leads to gastric distension and the potential for discomfort as well as vomiting. So if you have a patient who has a nasogastric tube in for venting, that's very helpful. Or if they have an implantable gastrostomy tube, I would recommend venting that to allow air to escape so that you're not pushing up on the diaphragm, decreasing your functional residual capacity, and also increasing their risk of burping and aspirating any gastric contents. Nasopharyngeal dryness in the past has been a concern, but most of our BiPAP machines and our ventilators that are BiPAP adaptable now have humidification, so that's no longer really an issue. And vasomotor rhinitis, conversely, as someone comes off the BiPAP and their nasopharynx vessels vasodilate after being on BiPAP, patients would complain of rhinitis. Again, because of the humidification, this is rarely an issue these days. Aspiration risk we've talked about. Full face masks, either the circumferential face or the nasal oral face mask, do place patients at risk for aspiration if they vomit into the mask. It is because of this in some of the smaller patients that we usually recommend just a nasal mask. If someone who's either too weak to pull a mask off, too weak to alert a provider that they vomited, or too weak to pull the mask off, nasal masks are a nice alternative. And we'll talk a little bit further about how to adapt for someone who's got a nasal mask with an oral leak. So air leaks are definitely a concern, either in the circuit, so make sure your circuit's affected, rather connected properly. Air leaks from the pleural space are unlikely to be caused by non-invasive ventilation, partially because there's definitely a dampening of the pressure dialed into the ventilator as it transmitted through the upper airways, and you're unlikely to develop significant air leak as a result of that. Now, the air leak, as it were, from the mouth, if you have someone just on a nasal interface, the air is being blown in through the nasopharynx. Some of it is being transmitted into the lungs, some of it to the stomach, and then some of it will actually be exiting through the mouth as the lower pressure gradient. A way to compensate for that is actually to either increase your flows and pressures, or sometimes we'll use a chin strap, a little bit of a jaw thrust, and other positioning just to help with that. remarkably, most patients, regardless of their sort of level of consciousness or development, can usually coordinate that the oral leak is minimal. Acute airway obstruction actually may be exacerbated by the use of non-invasive ventilation and is definitely something to watch for. When you apply a full face mask or the circumferential mask with the bonnet and the straps that go along with it, you may in fact actually displace the mandible backwards. As you put the mask on, there's pressure that's applied to the mandible and you may actually be forcing it back. And with that goes the tongue. And you may actually create a significant amount of retropharyngeal airway obstruction. The way to test that is, again, to do a jaw thrust, and that will help you identify the problem, and then really sort of address it. Again, you may be able to just loosen the straps a little bit, or transition to a nasal mask. If in fact you can't provide the amount of support needed with just a nasal mask, or it's not practical to provide continuous jaw thrust, you may need to consider transitioning to a translaryngeal airway or other types of support. Airflow-induced arousal or sleep disturbance. This is more of an issue for long-term patients on non-invasive ventilation, but certainly in a critical ill patient who's agitated because of the BiPAP, this is not necessarily tenable either. Long-term facial and sinus development is again a concern for the very smallest of children, patients with central hypoventilation or long-term lung disease, chronic airway obstruction, where they're wearing masks 12 hours a day for months and months at a time at a very young age. As the face develops, you can actually contribute to mid-face hypoplasia over time. There are times where people are not able to trigger the ventilator. Again, this is really dependent upon the type of BiPAP machine that you have or CPAP machine that you have and the type of interface. The more sophisticated models actually have spontaneous and timed modes or combined spontaneous and timed modes with varying degrees of flow or volume trigger and also mandatory rates. This is not an issue so much anymore that you can actually usually adapt the machine to meet the patient's needs, independent of their size or degree of weakness.
That concludes our video on non-invasive ventilation complications. Thank you. Please help us improve the content by providing us with some feedback. What did or didn't you like about this video? Was the content too simple, just right, or too difficult? Was the length too short, just right, or too long? Any additional comments? You can either click the Start a New Discussion button and type in feedback, or send us an email at openpediatrics@childrens.harvard.edu. Note, feedback is not required to complete this activity in the guided learning pathway.